Great. I'm just going on the YouTube channel. Just give me a couple of minutes. And I think people from China will join now. Are you also operating us today? Great.
I have to go.
Just going on the YouTube channel. Just give me a couple of minutes. Perfect. Just a minute. Please stop sharing all that. So what we need to do is I need to pin the thing from China.
You can hear me?
We can hear you.
Hi, Yazan.
Hi, Jiong. How are you?
How are you, Ash?
Fine, thank you.
Hi,
good to see you.
So what I'll do, let me pin your screen. Oh, that's pinned now. That's perfect. So we'll pin your screen because your screen will be the main screen. And
yeah, we have more than 10 colleagues here in this room.
Perfect. Perfect. That's fantastic. So I think we have 1,200 people registered. So I usually get 300, 400 of them joining online. But the numbers might be slightly unpredictable because I know it's late for you, but it's much earlier than my usual webinars. Everyone, can you just please leave a message from where you are joining on the chat function? It would be great to see. It's fantastic to see so many of you again and again on the webinars here. And it's good to see Ash after after a long disappearance from iBreastBook. So good to see him again. Now, Jiong, are you happy for me? I'll just open a little opening and then you introduce all your team and we start the talks. Is that okay?
Yes, of course, please.
And are we happy to start now? Or do you want a couple of other minutes?
I think we can start. Thank you.
Perfect. So, good afternoon, everyone. Not good evening. I'm used to the good evening, everyone. So good afternoon, everyone. It's another iBreastBook webinar, and this is a special webinar. It's in collaboration with Best from China. I think this is the first time we have people from China, and they have fantastic work, fantastic colleagues, but we don't always see what they are doing and what they are not doing. And it's great to have so many speakers, and I'm always thankful for Prof. Jiong and all his colleagues for staying late because they're in a conference now in Beijing, and they finished the conference at 7 o'clock in the evening for them now, and they're staying just for us for a couple of hours. We're trying to keep the iBreastBook team small because it's all about China this time. So I have the serial offenders. We have Andreas Karakatsanis again with us, which is one of the surgeons from Sweden, and he's the editor of EJSO. And we have Ash Kotari, who's currently now in Mumbai, and it's great to see Ash after we haven't seen him for a good few months now. So it's fantastic to see him again. The usual again, we have translation channels. If you want to listen to the talks in Russian, you go to the Russian channel. We have the lovely Tatiana. If we want to listen to it in Arabic, we have Akram Girgis, who's one of the surgeons from up north in England. Ricardo is online. It's fantastic to see Ricardo after that, but we're not going to use and abuse Ricardo. It's Roberto Lopez is going to do the Spanish channel, so we have a Spanish channel. And I'll hand over to Prof. Wu. We have already 266 people online, hoping to get more and more. Jiong, it's all yours now.
Okay, thank you, Yazan, and good evening for my colleagues in China, and also good afternoon, good morning for the global colleagues. I will invite Professor Wang Shu. She's sitting beside me. She's also the co-chairing of this meeting to have some speaking right now. Thank you.
Thank you, Dr. Wu, and it's my honor to be here, to be with Dr. Wu Jiong and Dr. Yazan to host this BAST group symposium. Although we have so many new advanced techniques in breast surgery area, but we do need to more fundamental stuff, like we need more training program, and we need more training platform and collaboration platform. So I think that's the aim we gather together to host this symposium. And first, So first, I want to invite Professor Wu Jiong and Professor Yazan to give us the opening speech.
Thank you. And today in this room, we also had Professor Sharon Chen from Hong Kong, and Sharon is now the president of BSI, Breast Surgeon International, and also Dr. Sadia Khan from United States and join us. And I have also more than 10 colleagues from all over China in this room. So I prepared something to speak at the beginning of this meeting because this is a very momentum moment for us. So welcome to Beijing, and my sincere pleasure to open this first. I think this is the first joint meeting of BEST program and the iBreastBook initiative. So I'm deeply grateful to each of you, whether you are joining us here in the Jade Room in Shangri-La Hotel, and all connecting from the United Kingdom, France, United States, Hong Kong, Malaysia, and other countries through online platform. So your presence, both physical or virtual, truly makes this global gathering tonight. So this moment makes a significant milestone. As many of you know, the BEST program has long been dedicated to advancing the breast surgical education and standardizing the clinical practice. For the first time, we are joining forces with iBreastBook. So this is a collaboration that I believe will amplify our shared mission. So together, we are not just sharing data, we are building a community that transcends borders. So one that is firmly committed to improving the quality of breast cancer care through better training, better evidence, and better collaborations. So looking at our agenda today, and I think I'm very excited to see the breadth and depth of the topics, and we will cover today. We will hear about the current state of breast surgery in China through a nationwide survey and explore the cutting-edge trial designs like CAPPELLA study and dive into the innovative techniques such as endoscopy, nipple-sparing mastectomy with immediate fat grafting, robotic-assisted breast reconstruction, and these are not just technical advances. I think they represent the future of our specialty, and they demand that we train the next generation of surgeons with the highest standards. So this brings me to the core vision of Dr. Yazan Masannat, many of our international colleagues, and I share the urgent need for structured, internationally recognized specialty training in breast surgery. We believe that every patient, everywhere, deserves a surgeon who is not only skilled, but also continuously learning and adapting. So today's exchange between East and West, between established leaders and emerging talents in this room and everywhere in the globe is exactly the kind of dialogue that will help us define and deliver that training. So I want to extend my heartfelt thanks to all the distinguished chairs, Dr. Wang, Dr. Yazan Masannat, and to all my dear colleagues, the moderators, speakers, panelists, for their generosity in sharing their expertise. So special appreciation also goes to our international guests who have taken the time for a long journey to join us, to bridging the time zones and the distances for the sake of our common purpose. As we begin this evening's program, I encourage each of you to engage actively, ask questions, and share your perspectives. The best ideas emerge when we listen and learn from one another. And please do not hesitate to connect with our online participants as well. And this is a truly hybrid event in spirit. So finally, I wish all the productive, inspiring, enjoyable meeting. So let's make the first best iBreastBook collaboration a stepping milestone towards many more fruitful partnership in the future. Thank you. So I will introduce the first session moderator, Dr. Sharon Chan. Can I introduce Sharon Chan? Can you show the slides here? Sharon 的简历有吗？哦 ，okay, okay. So, okay, good. Thank you. So Sharon is the clinical director of the Breast Center Kowloon East Cluster United Christian Hospital in Hong Kong. She's also the honorary clinical associate professor at the University of Hong Kong and the Chinese University of Hong Kong. And I think Professor Chan is also the president of Hong Kong Society of Breast Surgeons, and she's now the president of Breast Surgeon International. So please, Sharon.
Thank you, Professor Wu. It's a great opportunity for Breast Surgery International to join the BEST program. We share the common goal in contributing the academic exchange globally. And so Yazan and friends from all over the world, hi, I'm Sharon from Hong Kong. So it's also a great honor for me to introduce our first speaker, Dr.Benlong Yang. He is the Breast Surgery Associate Chief Physician from Fudan University, Shanghai Cancer Center. I think is the biggest cancer center in China. He is also the Secretary General of the Integrated Breast Cancer Committee, China Anti-Cancer Association, Standing Committee member of the Integrated Prevention and Screening Committee of Breast Cancer, China Anti-Cancer Association, and a lot of commitment and contribution in China breast cancer advancement. Dr. Yang, please.
Okay. Good evening and good morning also. Distinguished Professor Wu, Professor Wang, and Professor Yazan, and colleagues, friends. It's truly a privilege and honor to stand here to share with you the current landscape of breast surgery in China on behalf of Professor Wu's team. As many of you know, China now has one of the largest population of breast cancer patients worldwide. More than 420,000 women are newly diagnosed every year, accounting for like 1/5 of all global breast cancer cases. Such a large patient population creates tremendous pressure on our healthcare system, but also at the same time offers an extraordinary opportunity for clinical innovation, surgical standardization, and high-quality research. Today, rather than presenting the experience of a single institution, I would like to introduce findings from a nationwide survey conducted by Professor Wu that reflects whole breast surgical practice across China. This survey evaluates multiple aspects of breast care, including breast conserving surgery, axillary management, breast reconstruction, MDT care, patient-centered service, and so on. Most importantly, I hope this presentation will not simply describe where China stands today, but also stimulate discussion about where breast surgery should move in the coming decades. And let's begin with perhaps the most fundamental indicator of breast surgery, the adoption of breast conserving treatment. And you can see breast conserving surgery has become one of the most important indicators of quality breast cancer care worldwide. Our survey demonstrated a continuous increase in breast conserving surgery across China. The national rate has increased from approximately 12% in 2008 to 32% in 2024. This represents remarkable progress over the past decades. However, numbers alone do not tell the entire story. Compared to Europe or North America, where breast conserving rates may higher than 6% or even 70%, there is still considerable room for improvement. Why does this gap exist? Maybe, first, Chinese women generally have a smaller breast volume relatively to tumor size, making breast conservation technically more challenging. And second, patients often remain concerned about local recurrence, despite high-quality evidence demonstrated equivalent survival between breast conserving therapy and mastectomy. And third, regional disparities in radiotherapy accessibility continues to influence surgical decision-making, particularly outside major centers like small cities or countryside of China. Finally, surgeon experience and confidence in oncoplastic techniques also play an important role. As neoadjuvant systemic therapy, imaging technology and oncoplastic surgery continue to evolve, breast conserving surgery maybe will become increasingly common in the selected patients across China. And beyond the overall breast conserving, it's equally important to understand which patients are actually receiving breast conserving surgery. So when we examine breast conserving surgery according to tumor stage, several interesting observations emerge. So first, you can see stage 1 disease constantly accounts for the largest proportion of breast conserving procedures. Perhaps even more encouraging is the increasing proportion of stage 0 or DCIS disease undergoing breast conserving surgery, reflecting improvements in screening and early diagnosis of China. And conversely, stage 3 disease remains uncommon among patients receiving breast conserving surgery, which is consistent with current international guidelines. Interestingly, the breast conserving rate among stage 1 patients has increased from 40% in 2017 to over 50% to 2025. These findings suggest that surgeons are becoming increasingly confident in applying breast conserving approach when oncologic safe. However, one question deserves further consideration. If more than half of the stage 1 patients still undergo mastectomy, what are the remaining barriers? So, of course, increasing breast conserving surgery should never compromise surgical quality. One important quality indicator is margin status. And you can see that the positive surgical margins require re-excision remain an important quality metric in breast conserving surgery. Interestingly, our survey showed that in China, the majority of hospitals report reoperation rates below 10%. That's so different from the foreign hospitals like 20 or even 30%. So, which appears lower than many published international series. At first glance, this may seem encouraging. However, interpreting these findings requires caution because a low re-excision rate does not necessarily indicate a super surgical quality. If it may instead reflect that more conservative patient selection or wider initial excision. In other words, avoiding reoperation should never come at an expense of unnecessary removal of healthy breast tissue. And this finding illustrated an important principle in modern breast surgery. Quality is determined not only by a single number, but by balancing oncology safety with cosmetic preservation. So I think maybe later we can discuss of that. And the survey also demonstrated that breast conserving surgery following neoadjuvant therapy continues to increase across China. And you can see these trends reflect growing confidence among surgeons in operating after substantial tumor regression. Nevertheless, another interesting observation emerged. Despite remarkable improvements in pathological PCR rate, particularly in HER2-positive and triple-negative disease, the actual conservation to breast-conserving surgery remains lower than expected. This may suggest that systemic therapy alone is insufficient. Successful breast conserving also depends on acute pre-treatment localization, high-quality imaging, and MDT discussion, and sophisticated oncoplastic technologies. So further progression therefore requires not only better drugs, but also better surgeries. And as surgeons become increasingly confident in preserving the breast, attention naturally shifts towards preserving appearance as well. So OPS now is a very popular topic now among the Chinese breast surgeons. Our survey demonstrates that increasing adoption of oncoplastic techniques throughout all China. Like Professor Wu, we held more than, I think, 10 training course in nationwide every year for OPS. You can see that volume displacement remains the dominant strategy, accounting for more than 80% of procedure, whereas volume replacement technologies are less frequently performed. This pattern is understandable because the volume displacement is technically less demanding and can be applied in a majority of patients. However, as breast conserving indications continue expanding, volume replacement technologies will become increasingly important, particularly in women with smaller breasts. So it's equally about preserving body imaging and quality of life. While breast conservation continues evolving, another major paradigm shift has occurred in axillary surgery, surgical de-escalation. So first, sentinel lymph node biopsy for clinical nodes negative patient has achieved a ultra high penetration. You can see that SLMB coverage rise from 90% in 2022 to 93% in 2024, basically replacing routine axillary dissection for early stage patients now in China, which greatly reduce lymphedema risk. More importantly, axillary de-escalation after limited sentinel lymph node involvement has made steady progression. For the patient with 1 to 2 positive sentinel nodes receiving breast conservation, ALND exemption rate increased from 32.3% to 43% within 2 years. For mastectomy counterparts, the rate doubled from 12% to 26%. And let's shift to breast reconstruction. The first set of macro data shows revolutionary progression in service accessibility. By 2024, 96% of surveyed medical institutions have launched breast reconstruction services, a huge leap from 87% in 2017. Only 4% of the hospitals still cannot provide reconstruction due to equipment or manpower constraints. Even more encouraging is patient-informed consent practice. 99% of the surgeons will actively introduce reconstruction options to mastectomy candidates in 2024, compared with merely 80% in 2012. This demonstrates that the Chinese clinical teams have fully recognized the psychosocial value of breast reconstruction and recovery has become a standard part of preoperative communication workflow. And the remaining challenge is unequal access. Country-level hospitals almost lack independent reconstruction capacities, relying on referring to territory cancer center. And we further analyzed the reconstruction timing and the surgical modality preference. For timing selection, immediate reconstruction dominates clinical practice, accounting for 77% of all reconstruction cases in 2024, up from 66.9% in 2022. Delayed reconstruction dropped to only 11%. Maybe more patients select immediate reconstruction. And the patient and surgeons both prefer one-stage stimulates resection and reconstruction to avoid secondary surgery, trauma, and psychological stress. That's very interesting in China. Most patients will choose one stage. In terms of reconstruction method, implant-based reconstruction is the absolute mainstream, taking 76% market share, and autologous tissue flaps accounts for like 20%, and the combined reconstruction only 5%. The reason is obvious. Implant surgery has shorter operation time, lower technical threshold, and broader cost coverage by medical insurance in most regions. Some regions even will cover the mesh expense. But for the autologous free flap reconstruction is still concentrated in top cancer hospitals with microsurgery platform like our hospital, Professor Wang's hospital, and so on, which we will elaborate about the next slide. And for the implant reconstruction, biological and synthetic mesh patches are critical to reduce capsule contraction and expose risk. Our survey tracked two mainstream products, tie-loop mesh and ADM. Tie-loop mesh has achieved expansive popularities. Hospitals' usage reached to 90% in 2024, compared with only half in 2017. Synthetic mesh has advantage, but on the contrary, ADM application remains stagnant. Only around 20% of hospitals routinely use ADM from 2022 to 2024. We also found that 46% of the hospitals have over 80% of their reconstruction cases purely implant-based, which reflects that current technical bias toward simple implant reconstruction nationwide. And this is an overview of autologous reconstruction over the mainland of China. You know that autologous tissue reconstruction represents high-end breast surgery, and its development status exposes the technical hierarchies of Chinese breast surgery departments. ALD flap is the most mature autologous technicals in China. 70% of the hospitals can independently complete this operation in 2024. It has low microsurgical surgery requirements and is widely used for small volume breast reconstruction. And a pedicle tram flap is available in nearly half of the institutions, which free abdominal flaps are still technical restricted. Only 28% of the hospital can perform free flap independently. Another 17% need extra senior microsurgery experts for assistance. More than half of the hospitals cannot carry out free autologous reconstruction at all. So this imbalance reminds us that a national microsurgery training system for breast surgeons needs to be accelerated to narrow the technical gap between top centers and the regional hospitals. Moving from surgical technicals to PRO evaluation, a critical shift from disease-centered to patient-centered care, you can see that up to 2024, 74% of the hospitals have introduced standardized PRO measurement tools, a steady growth from 65% to 2017. Thanks to Professor Wu's team, we translate the breast Q to the Chinese version. So you can see among these institutions, 85% of the hospital take a breast Q Chinese version as a core evaluation scale, which has become the golden standard for domestic breast reconstruction, aesthetic and quality of life assessment. And next session will focus on the minimal invasive breast surgery, including endoscopic and robotic assistant platform. And you can see that first, our pooled retrospective meta-analysis, including over 4,800 patients, confirmed that core safety conclusion, long-term overall survival and local recurrence-free survival shows no statistic significant difference between the traditional open breast surgery and endoscopic surgery. In terms of clinical penetration, endoscopic breast surgery now more and more popular in the mainland of China. In 2022, nearly 47% of the hospitals performed endoscopic routinely. Now I think in the 2024, this number reached to 89%. Maybe in the 2026, this percent will up to 90 or 95%. The hidden challenge is a steep learning curve. Endoscopic procedures are still not standardized nationwide. Robotic breast surgery is still in the preliminary evaluation stage. Only 12% of the hospital now carry out robotic operations in 2024, up from 4% in 2022. The biggest bottlenecks are high equipment cost and limited machine allocations, restricting robotic application to a small number of high-level cancer centers. Okay. And upper limb lymphedema is disabling long-term after squeal after breast cancer axillary surgeries. So over 2024 survey showed that 57% of the hospital control post-operative lymphedema incidence within 10%, while 32% of the institutions face incidence between 11% to 20%, indicating uneven axillary operation quality and post-operative rehabilitation guidance. And now we step into hospital department high-quality constructions, two core pillars, daytime surgeries and also MDT. And you can see that based on national examination indicators, daytime diagnosis and treatment as well as MDTs are now routinely do that in the 90% of the hospitals. Up to 2024, 62% of surveyed hospitals have launched systemic breast cancer daytime diagnosis and treatment services. And for the innovation, medical technology, and conventional diagnosis and treatment centers, empower the daytime diagnosis and treatment, enhancing the efficiency of diagnosis and also the treatment. And that's the advantage and obstacles of implemented that we can skip that. Okay, let's move to the summary. You can see that with the construction of clinical specialty capacity as a driving force, we aim to the high quality development of public hospitals and contribute the strength of breast surgery to achieve the grand goal of healthy China. And now we are improving our breast conserving surgery rate, and we improve our breast reconstruction quality. And however, with various development technology, it has become increasingly important to provide patients with more precious and suitable surgical and treatment method. That's all my present today, and thank you all. Thank you.
Thank you, Professor Yang, and for sharing with us the very important data and a very comprehensive review. We understand the data from China, the obstacle, and you also have a great suggestion on how to overcome the obstacle. Although with time limit, we can just skim through it. Shall we have question now or later? Okay, thank you.
The question after, Sharon. That's a fantastic talk, great overview. Please have a look, people that are online, please have a look at the chat function and have a look at the Q&A function. You can leave questions on the Q&A function before we go to the next speaker. Back to you now.
Can we see the chat box for the questions? Okay, we will collect all the questions and leave the question and answer session later. Okay, Yazan? So we will move forward and keep the time.
Fantastic.
Okay, Professor Wang, would you please introduce the next moderator?
Okay, let's move on to the next section. I will introduce Professor Song Guohong to moderate that part. And Song Guohong comes from Beijing Cancer Hospital. She works as the Department of Medical Oncology. So she's the only medical oncologist in this group this evening. So she's very precious, and she have so experienced in the medical oncology treatment and also radiology treatment. So very much the topic he moderated. So welcome, Professor Song.
Okay, thank you for Professor Wang Shu's introduction. Good evening, everybody. It's my honor to be here. You know, I'm the only physician in this room, so that's my honor. The next topic is about radiotherapy and surgery. So I don't very familiar with this part. I don't know why ask me to moderate this part. Anyway, I'll try my best to do a good job. So let's invite next speaker is Dr. Shuang, Hao Shuang from Fudan University. 好什么呀？好爽啊 ！Sorry， 好爽。English. Dr. Hao Shuang from Fudan University Shanghai Cancer Center to share a clinical trial. That trial is a CAPPELLA trial study. It's about the plan and the schedule. You can see the introduction of Hao Shuang by yourself. Okay, welcome Hao Shuang to give us a presentation. Please, Hao Shuang.
Thank you, Dr. Song, and nice to meet you, everyone. Dr. Andrews, Dr. Yazan, Dr. Ash, and Dr. Sharon. And I'm online, and I show you my PowerPoint. And good evening, colleagues. And I'm Hao Shuang from Fudan University Shanghai Cancer Center. And at our center, we see about 12,000 breast cancer cases annually and perform maybe over 200 DF flap per year. So that volume allows us to ask meaningful clinical questions. So today I will present the CAPPELLA trial, which is under the leadership of Dr. Wu. It's a multi-center randomized open label phase 3 study comparing the pre-operative radiotherapy versus conventional post-mastectomy radiotherapy in patients undergoing immediate DF flap reconstruction after neoadjuvant chemotherapy. And this is the analysis of secondary endpoints at 3 months. So let me set the stage with the clinical problem we were trying to solve. So post-mastectomy radiotherapy, or PMRT, is a standard for high-risk disease. So it reduces local regional recurrence and improves survival. But when you deliver it after immediate autologous reconstruction, the flap receives radiation. So data from MROC study show that for patients receiving PMRT, autologous reconstruction has significantly lower complication rates than implant-based reconstruction. But PMRT still, post mastectomy radiotherapy but PMRT still lowers breast satisfaction in both reconstruction types with a larger drop in implant-based patients. In meta-analysis of 21 studies, including almost 4,000 autologous reconstruction patients, PMRT significantly increases fat necrosis, fibrosis, contractures, and volume loss. And also in our center data from 185 DF patients, PMRT resulted in higher fat necrosis and lower aesthetic ratings. So the dilemma is clear. PMRT is oncologically necessary, but it harms the constructed breast. So delaying reconstruction avoid radiation damage, but patients live without a breast for months, carrying significant psychosocial burden. So we ask, what if we flip the sequence? What if we deliver radiotherapy before mastectomy? So preoperative radiotherapy, also called neoadjuvant radiotherapy, offers several theoretical advantages. First, it avoids irradiating the autologous flap. The flap is transferred after radiation is complete. Second, it allows more precise target delineation because the breast and chest wall anatomy is intact. And third, it avoids treatment delays caused by post-operative wounds complications. And fourth, it can streamline the overall treatment pathway and shorten total treatment duration. So, and a systematic review, including 18 studies, showed that preoperative radiotherapy followed by breast reconstruction had complication rate of 3 to 36%, excellent to good aesthetic outcome of over 66%, and PCR rate is the same with the PMRT. So local recurrence is low, but longer follow-up was needed. And the most notable study before ours was the PRADA trial. It's a multicenter prospective single-arm study from UK, and 33 patients received preoperative radiotherapy followed by skin-sparing mastectomy and depth reconstruction. And the primary endpoint was incision adherence over 1 centimeter at 4 weeks. And they observed at a 12.1 rate 4 out of 33 patients. But importantly, breast Q satisfaction scores improved dramatically from a median of 48 at baseline to 33 at 3 months and 73 at 3 months and 77 at 12 months post-surgery. PRADA showed that preoperative radiation was generally safe with no serious adverse events, but they concluded that prospective randomized controlled studies are needed. So that's exactly what we did. So the purpose of CAPPELLA was to compare the effects of preoperative radiotherapy versus postoperative adjuvant radiotherapy on satisfaction, quality of life, and safety in patients undergoing the intermediate abdominal free flap reconstruction after total mastectomy. So our hypothesis is preoperative radiotherapy is associated with higher breast satisfaction than post-operative radiotherapy. The primary endpoint is breast satisfaction measured by breast Q at 24 months post-operatively. And the second endpoints, including total PCR, the surgical complications, the radiotherapy-related complications, and the PRO at 3 months, at 12 months, and 24 months using breast Q. And aesthetic rating use Harris grading and 3 years DFS, LRFS, and OS. And this 3 months analysis focuses on safety, PCR rate, and treatment efficiency, and early PRO. So CAPPELLA is a multi-center prospective randomized and open label phase 3 trial and conducted at 3 centers in China. So the patients all have stage 2 or stage 3 breast cancers, received neoadjuvant chemotherapy and indications for PMRT, and plan to undergoing DF reconstruction. And patients were randomized 1:1 to 2 arms. The first one is preoperative radiotherapy arm, neoadjuvant chemotherapy, and then after 3 to 4 weeks, and then underwent a pro-operative radiotherapy, and after 2 to 6 weeks, underwent NSM or SSM with DF flap. And PMRT arm is also neoadjuvant chemotherapy after 3 to 4 weeks, and NSM or SSM with DF flap, and within 12 weeks, underwent the PMRT with the same dose. And this is the inclusion criteria and the exclusion criteria, and some same sample and the sample size calculations. And the radiotherapy target is the same in the 2 groups. People will be treated with hypofractionated radiotherapy, and the dose is the same, 42.57 gray in 16 fractions. And we'll see the flow chart. At last, 89 patients were randomized, and 45 to preoperative radiotherapy, and 44 to PMRT. And at the data cut off, 78 patients had completed 3 months follow-up and were included in this analysis. 36 in the pre-operation group and 42 in PMRT group. And the baseline characteristics were well balanced between the 2 groups. And let me highlight a few key points. The mean age for 40.9 years in pre-op group and 39.5 years in PMRT group. And most patients had a clinical T2 to 3 tumors and clinical node positive disease. And the molecular subtypes were similar distributed. And importantly, the proportion of nipple-sparing mastectomy was similar between groups, 41.7 in the pre-operating group versus 45.2 in the PMRT group. But in product trial, I think all the patients underwent SSM, no NSM mastectomy. Yeah, that's the difference between a CAPPELLA and PRADA. And let me show you the analysis of the over PCR rate. We see the total PCR was achieved in 25% in the preoperative group versus 21.4 in the PMRT group, and no difference. The p-value was 0.71, and breast PCR rate were also similar, 27.8 versus 21.4. So delaying surgery for radiotherapy did not compromise tumor response. When we look at PCR by molecular subtype, we see the expected pattern. HER2 positive and triple negative tumors have the highest PCR rate in both arms. But importantly, there were no meaningful difference between the two treatment arms across any subtype. So this confirms that the addition of preoperative radiotherapy does not selectively benefit or harm any particular molecular subtype. Yeah. Now complications, because nobody wants a flap that doesn't fly. So we defined a composite endpoint. The major delayed wound healing includes open wound over 1 centimeter requiring dressing and new nipple areola necrosis at 4 weeks, because it's the difference between product. We have over 40% patients underwent NSM. So the incidence was 2.5 in the preoperative group versus 7.1 in the PMRT group. And the absolute difference is 4.3 percentage point with a wide confidence interval. So we cannot say it's better, but we can say it's not worse. No flap loss occurred in either group, and fat necrosis rates were low and comparable. So importantly, CAPPELLA included a substantial proportion of nipple-sparing mastectomies, about 42 in both groups. So whereas PRADA, exclusively using skin-sparing mastectomy. So our complication rates were lower than the 12.1 point reported in PRADA. So a preoperative radiotherapy does not increase early surgical risk. Now let me show you the time, because time is money, but time is time is the patient's sanity. So interval from last chemotherapy to completion of all local therapy, surgery plus radiation was 67.5 days in the preoperative group versus 113 days in the PMRT groups. Where did the time go? Let's break it down. The interval 1 from chemotherapy completion to the next therapeutic step was 23.5 days in both groups, no difference. And the interval 2 is where the divergence occurred. In the preoperative arm, surgery was performed a median of 22 days after radiotherapy. And in the PMRT arm, radiation was initiated a median of 68 days after surgery. That 68 days waiting period requiring for wound healing is a structural dependency of the conventional sequence. And by flipping the sequence, the preoperative strategy eliminates this waiting period entirely. So there's no magic, just smart sequencing. So baseline breast Q satisfaction scores assessed before any local treatment were comparable between group. It's only 4 scores, but no significance difference. And at 3 months after reconstruction, scores improves in both groups compared with baseline. So in conclusion, for patients with local advanced breast cancer scheduled for neoadjuvant chemotherapy and immediate depth reconstruction with a non-indication for radiotherapy, and preoperative radiotherapy is feasible and safe. It provides comparable early complications with no increase in flap loss and fat necrosis, and it achieves a 45 days reconstruction in total local treatment duration. And what can we do next? We will follow up the long-term follow-up is ongoing for the 2 years breast Q. And it's our primary endpoint, and aesthetic outcomes and quality of life and late radiation toxicity like fibrosis, cardiac toxicity, and oncological safety like DFS, OFS to be reported. And thank you for listening. That's all. Thank you.
Okay, okay. Thank you for Dr. Hao Shuang the excellent presentation about the radiotherapy timing for the patients received intermediate breast reconstruction, pre-operative or post-operative. From her presentation, we can get something important. Maybe for the pre-operative radiotherapy, it doesn't influence the result, and maybe it can reduce the complication, and we also try to follow up long-term follow-up to see the long-term result. For anymore, I think for the timing radiotherapy, pre-operative radiotherapy is a choice for in our clinical practice. Okay, thank you very much for Dr. Hao Shuang the excellent presentation. Okay, now let's invite next moderator Lin Ying from. Okay, you can see by yourself, Director of the Department of Breast Surgery from Sun Yat-sen University. Okay, please, Lin Ying.
Thank you. Yeah, good evening, dear friends, either online or on site. I'm Lin Ying, the moderator of this section. So we have heard about the landscape of surgical strategy of breast cancer in China, and also one of the clinical trial. And now we move to the practical surgical technique. Let's welcome Dr. Song Xue from Guangdong Province Hospital of Chinese Medicine. She's going to share us some of her experience about the endoscopic nipple-sparing mastectomy combined with multistage autologous fat grafting for total breast reconstruction via the axillary incision. So please, yeah, Dr. Song. So is the slide ready?
Yes.
Yeah, okay. Yeah, please.
Okay, thank you, Dr. Lin. Good evening. I'm very delighted to share our work on endoscopic nipple-sparing mastectomy with immediate multi-stage fat grafting for total breast reconstruction via a very hidden axillary incision. And I'm Dr. Song Xue from Guangzhou. In this talk, I will introduce why we explore this technique and how we perform it, and also the outcomes so far, including the cosmetic results and some complications and our follow-up. So here's my disclosure. Let's begin with a case 31 years female, you can see from the picture with BMI nearly 20 and was diagnosed with, as DCIS in her right breast and with diffuse calcification. So she is not a candidate for breast conserving surgery. Now, this woman plan to mastectomy, so she prefer for immediate breast reconstruction. So what's your surgical plan? Implant-based or flap-based? Currently, I think implant-based reconstruction is widely used in China, as Professor Yang mentioned before. However, we can see capsular contracture, hardness, and implant loss even. So maybe the patient who is a candidate for radiotherapy, I think the situation is even worse. But for the flap reconstruction, you may encounter some flap necrosis and extensive scars on the donor side, and not all the patients are suitable for the flap reconstruction because the very long recovery time and very long operative time. So even for the very young patient, they don't want to have the extensive scars on the donor side. So it is the main concern about the flap reconstruction. Now we're back to this case. This woman has relatively small breast volume and she prefers natural appearance. And she wants to use autologous tissue without visible donor side scars. So we try to find, is there alternative plans for her to do this immediate breast reconstruction? And previous studies have reported a very better quality of life. We can see use flat grafting reconstruction. Immediately, they can achieve a better quality of life. So inspired by that, as Professor Yang mentioned before, recent years in China, even in Asia, endoscopic E-NSM are popular. So inspired by that, we try to give her a minimal invasive mastectomy. So we use endoscopic E-NSM. Before we do the operation, we must do some pre-op markings. So here we show some very important marks, such as inframammary fold, and we mark the breast margins. And so we choose a very hidden incision that's in the armpit. And the donor side, we choose bilateral dies. And the woman is, we estimated breast volume was about nearly 200. So we try to use alternative procedures for her. This is our procedures, and I will show you the videos. Let's move on the videos. 需要开一下声音，会务组。First, we perform sentinel lymph node dissection, and we send them to the frozen section, and we mark the breast margin by blue dye. And after that, we do the E-NSM through this axillary incision. We use single pot, and it's a reverse sequence. So we just do retrosubpectoral dissection, and then we move to the subcutaneous layer. After that, you can see the whole gland was decided out. And second, we do the liposuction. So we have two teams. Sorry, move back. After we finish the E-NSM, the other team is prepared for the liposuction. And we use tumescent anesthesia and Coleman technique for the liposuction. And third, we will purify the fat. Yeah, we put the fat into the centrifugation. Then we put out, and we also use a pad to absorb the tumescent fluid. This is how we purify our fat. So I will show you the process of the procedures. Now is the purified fat. We just do the lipo injection in the subpectoral layer. And after 6 months, the second procedure, it's very important that we need to release the subcutaneous adhesions, because if we don't do that, we cannot put much fat into the breast. And at this time, we have 2 layers. One layer is subcutaneous, and the other is subpectoral layer also. And after the second procedure, you will see the cosmetic outcome later. So after 2 procedures, you can see these women have a fat grafting reconstructive breast, and we removed the specimen about 173 grams, and we put nearly the first procedure we put 200 millimeter, and the second procedure we put the same volume to her. And after that, you can see the breast contour is improved over time. Now we can see the cosmetic outcome improves over time, and we generally prefer the patients with relatively small to moderate breast volume. And if she had adequate donor fat, we can use this technique to do the breast reconstruction. And even for the very young women, she do not want to do the implant-based reconstruction, so we use this technique for many smaller breast patients. And here are some cases from our series. From the video, you can see the model. You can see a very natural and soft breast. Okay, most patients from the patient characteristic, you can see most patients had relatively small breast volume with the cup A to B, and the fat volumes we put was usually between 300 to 400. And most patients underwent 2 procedures, and the surgery operation time takes less than 4 hours. So it's very similar to implant-based reconstruction. And by the way, this technique is not hard to manage. You can find from this learning curve, after 10 cases, the total operative time becomes stable, and the early complications we observe, including about NAC ischemia and bleeding. In our series, only 2 cases develop nipple ischemia, and 1 case develop hemorrhage. So during the follow-up, we use MRI, ultrasound, and mammography. During the follow-up, you can see MRI showed an average of fat retention rate about 64. It's very similar to the publications. And the ultrasound decided some oil cyst in some cases. And the mammography in early follow-up, you can see no calcification. But this very early follow-up, so we So we expect a long-term data after that. And I think this image findings helps us understanding the fat retention and evaluate whether the post-op changes may interfere breast cancer surveillance. At present, our follow-up remains limited, and longer-term image and oncological safety are still needed. We shared our work on ACS Clinical Congress in 2025, and currently we are collecting more data for publication and conducting a multi-center RCT to evaluate long-term outcomes, including oncological safety, long-term outcomes, and some cost efficiency. So to summarize, this technique, I think, endoscopic nipple-sparing mastectomy with immediate multi-stage fat grafting through a hidden incision, it's just very suitable for the very smaller breast volume patient, and some advantages such as minimal invasive approach instead of extensive visible scars across the breast, and very lower donor side mobility instead of some flap necrosis. And also it will improve quality of life, and it will achieve a better cosmetic outcomes. But for the limitation, I think multiple procedures are required, and the fat retention rate are variable. So long-time data, including the oncological safety, we still need it. But I think this unique reconstruction is suitable for our Asian breast cancer patient, because our patient often have a very smaller breast volume and it's not that big. So maybe 2 procedures they will accept, and they will achieve a very good, a better cosmetic result. And thank you very much for your attention, and thanks for having me. This is our team. Thank you.
Thank you very much, Dr. Shuang, for your brilliant lecture. So actually, she introduced the patient selection indication and perioperative management, and also the key point of the detail, the technique detail. So one quick question. So you mentioned about you inject the fat into 2 layers. One is subcutaneous. The other is behind the major pectoral muscle. Between, okay, yeah. Okay, thank you. So we'll close this section. Let's move on. Please welcome our next moderator, Dr. Ye Jingming. He's the director of the Department of Thyroid and Breast Surgeon in the Peking University First Hospital. Thank you.
It's truly an honor for me to have this opportunity to participate in this meeting, and thanks for having me to be the moderator for this section. Now we are going to enjoy the last feathered lecture of today's agenda. Let's welcome Dr. Chaobin Wang from Peking University People's Hospital, who will speak on robotic breast reconstruction. Robotic surgery represents the core intelligent development direction of modern breast surgery, and Dr. Wang owns extensive experience in robotic breast procedures. Let's give our warmest welcome to Dr. Wang. Dr. Wang, let me introduce. Okay, going on.
Thanks for Professor Ye. Good evening, professors and colleagues. It's a great honor to have this opportunity for academic exchange. I'm Wang Chaobin, breast surgeon from Breast Center, Peking University People's Hospital. Today, my presentation is on robotic mastectomy and breast reconstruction. My presentation will cover three main aspects: the rise of robotic breast surgery, the safety of robotic breast surgery, and how we perform robotic mastectomy and breast reconstruction in our center. Let me begin with the first part. In 2015, Professor Tesser first reported robotic-assisted nipple-sparing mastectomy. 3 women with genetic mutations underwent NSM. The surgeon concluded that this was a safe procedure with excellent cosmetic outcome. Following 2015, a number of cohort studies were subsequently published. However, in 2019, the FDA issued a safety communication raising concerns about robotic breast surgery. But the same year, a consensus statement on robotic mastectomy was published to support robotic surgery. Now, this safety communication is no longer available on the FDA website. The 2019 consensus statement provided a detailed overview of robotic breast surgery, including indications, contraindications, and key points for pre-operative, intraoperative, and post-operative management. And so as this, it's so detailed, Since then, an increasing number of publications have reported on robotic breast surgery. And this too. I think the advantage of robotic breast surgery includes enhanced precision, super 3-dimensional visualization with magnification, and more surgeon-friendly and comfortable. Of course, robotic breast surgery also have several disadvantages, including higher cost, limited accessibility, specialized technical training, and an experienced operative team, and also the lack of haptic feedback. Next, let me move on to the safety of robotic breast surgery, including oncologic safety and surgical complications. A small RCT study reported oncologic safety data. However, this study had only 80 patients. 40 underwent robotic NSM and 40 underwent conventional NSM. Oncologic safety was a secondary endpoint with a median follow-up of 28 months. No local recurrence were observed. A systemic review and meta-analysis, including 6 articles, found no statistically significant difference in positive margin rates between robotic NSM and conventional NSM. 4 of these studies reported earlier recurrence data, and the recurrence rate were comparable between the 2 groups. Another international multi-center pooled analysis, including 659 women, and also found no statistically significant difference in local recurrence between robotic NSM and conventional NSM. There were also no statistically significant difference in DFS and OS. Overall, there is currently a lack of prospective large-scale data to support the oncologic safety of robotic breast surgery. A prospective cohort study from Korea is now underway, including 3 groups of patients. The target number of enrolled patients is 2,000. Oncologic safety is included as a secondary endpoint. We look forward to the result of this study. A number of studies have reported on the safety profile complications in robotic surgery. One meta-analysis included 7 studies with a total of 1,674 patients. Grade 3 or higher complications were less frequent in the robotic surgery group. Nipple necrosis were also less common with robotic surgery. Additionally, the cerebral rate were lower in the robotic group. Regarding operative time, conventional surgery was superior. However, the robotic surgery group had less blood loss. Data from another meta-analysis showed no statistically significant difference in complications between the robotic and conventional surgery groups. Therefore, robotic surgery is considered a safe surgical approach.
Just go and see.
Now let me introduce our surgical approach and the technique for robotic surgery. We make an axillary incision approximately 4 to 5 centimeters. Sentinel lymph node biopsy is also performed through this same incision. The robotic arm were allocated and CO2 insufflation were used. We used a single port robotic system manufactured in China. We used a bipolar gasper in the left hand and a robotic electrocautery scissors in the right hand. The left hand provides traction and counter traction, while the right hand dissects the retromemory tissue. For the subcutaneous layer, we used a scalpel for dissection. The purpose is to minimize thermal injury to the skin and prevent skin flap necrosis. Using a dedicated long shaft injection needle, we perform subcutaneous infiltration of this epinephrine saline solution, primarily to reduce intraoperative bleeding. We then used a scalpel to dissect the subcutaneous fat layer. Recently, we have also been exploring a combination of blunt dissection and scissor dissection. We have found that this combined approach results less bleeding. We look forward to sharing this method in the future. After completing the superficial dissection, we reinsert the robotic instruments to divide the facial tissue surrounding the gland. The glandular spaces is then removed. We wrap the implant with a titanium mesh patch using sutures, ensuring complete coverage of the implant surface. This serves two purposes. First, it provides some anti-infective effect. Second, it helps secure the implant in position and reduce the risk of implant displacement and rotation. The implant is then inserted through the surgical incision and placed in the pre-pectoral pocket. After implant placement, we use sutures to fix the titanium mesh. This helps reduce implant displacement and rotation. The two J tubes are placed. It's a video just finished this week. We made an axillary incision for sentinel lymph node biopsy. Through the same incision, we dissect the superior and the lateral retromemory space. Then we dock the robotic instrument to the dissection the retromemory plane. We used bipolar grasper in the left hand and the monopolar electrocautery scissors in the right hand. After completing the retromemory dissection, we infiltrated the subcutaneous plate with epinephrine saline solution, then used a scalpel to dissect the subcutaneous tissue. The robotic instrument were reinserted to divide the tissue surrounding the gland. Following grand removal of the pocket was irrigated and a sizer was placed to determine the appropriate implant size. It's a sizer. The implant was then wrapped with titanium mesh. Then we insert it into the pocket and sutured in the place. Because this surgery performed this week, so the picture is not available now. That concludes my presentation. Thank you again, professors, for your presentation. These are groups photos from our center and from our robotic surgery training sessions. I look forward to more opportunity for exchange and collaboration with all of you in the future. Thank you very much.
Deep appreciation to Dr. Wang for this insightful sharing. He comprehensively introduced the technique strengths, operational challenges, applicable scenarios, and global progress of robotic breast reconstruction, allowing us to fully understand how intelligent surgery innovates breast reconstruction practice. And all 4 keynote lectures have been successfully completed. Now, we are arriving at the highly anticipated international panel discussion section. Let's hand the floor to our panel moderator, Dr. Xin Wang. And you can see the brief. Okay.
Thank you, Dr. Ye. And I'm Dr. Xin Wang from National Cancer Center of China. And very glad to be here to hold the panel discussion. Hi guys, we have a panel discussion I'm hosted last month, right? So we moved to the online and the offline part. So today we have 8 experts to join our discussion. Actually, I think all of you, if you have questions, you can talk. You can just say something out. Yeah.
Perfect. Jiong, how are you?
Okay. Yeah, good. Hi, Yazan. I saw your questions from the the WeChat. Yeah.
Perfect. So there's lots of
Yeah.
things to discuss, and there's lots of things. By the way, fantastic talks, lots of interaction online, lots of people asking fantastic technical talks, fantastic also the oncology and surgical talks. And we have with us online, we have Andreas Karakatsanis, who's one of the surgeons from Uppsala in Sweden, but he's also, his other hat, he's the co-editor of the European Journal of Surgical Oncology, which is one of the biggest surgical oncology journals in Europe. And I'm not sure, is Ash still online? Because Ash will be fantastic if he's also still online. And you have quite a few people from your side also. Do you want to introduce the people from your side before we start taking the questions?
Okay, thank you. Thank you. Welcome, Dr. Ashes, and welcome our colleagues from Europe. Okay. Now I introduce the expert from here. Now in here. So Dr. Sadia Kahai, and is she? Oh yeah, right here. Yeah. The camera's right there. So yeah.
Hi, I'm
Say hi.
very
Yeah.
happy to be here. Thank you.
Perfect.
Okay. And
So, yeah.
Dr. Sami Hong from Malaysia.
Perfect.
Yeah, we had a focus. Okay. And I can Dr. Gong Chang from Guangzhou right there. No, not we are in Beijing, but she's from Guangzhou. But she fly to Beijing now. The camera. 工厂的举个手，他摄影师对 ，OK, right there, yeah. And beside her is Dr. Miao Liu from Beijing. She's also the host of the conference too. Okay, so Dr. Wenyan Wang from Beijing too. She's from Tiantan Hospital.
Perfect.
And also Dr. Wang Yu from Tongren Hospital in Beijing. And the last one be our Dr. Ho Puyang from Beijing University People Hospital, also the host of this conference too. So we have actually seven panel right here. Okay, so let's move to the QA part.
So let's start with the questions, because I was texting Andreas and Ash also when the talks were happening, and fantastic talks. And the first talk was mainly talking about what's happening in China. Any comments about that, Andreas?
I think that we are seeing a very fascinating and evolving landscape with more uptake of breast conserving rates, which is where we need to go. I mean, I think that we are all in agreement that the best mastectomy is no mastectomy nowadays, and it is very fascinating to see how things are catching up. There is vast scientific data produced in terms of clinical research from China these days. I think that all our colleagues in China have to be commended for the harmonization to standards such as the validation and the translation of the breast Q. This is very, very important, as it is going to allow for comparisons in the future, since we know that quality of life becomes more and more important, and the use of validated questionnaires is very, very important in order to be able to move forward and to be able to compare outcomes in populations regardless of cultural background and characteristics. And finally, I think that the CAPPELLA trial is very, very fascinating. It is on the correct direction as to looking into sequence inversement with the use of preoperative radiotherapy. I think that the first hints of results that we looked at today are very, very promising. I think that it just set the bar very high, or even higher up, for Prada 2, that is going to start recruiting in the UK. And we are excited to see how that is going to look like. But all in all, a lot of very exciting things. I think that the interest in endoscopic and robotic techniques, finally, which is on the rise because there is a hype in the world, is going to find its place at some point. I have a strong idea of that once Chinese surgeons grow more comfortable around oncoplastic techniques and volume replacement techniques, and less mastectomies will be performed. I think that the interest in endoscopic or robotic techniques will stabilize into lower levels probably. That's my 5 cents.
Perfect. And I must say, because we're trying to be part of Prada too, and next door, I'm in theaters now, and next door is Adil Khan, who's one of the main authors of Prada 1, and he'll be one of the main authors in Prada 2. Fantastic study. There's a couple of questions about the study, and if we can take those. So Jamila Al-Azhari from Saudi Arabia is asking, what was that window for irradiation therapy before having the surgery? Any comments on that from the product from the CAPPELLA study?
Yeah, any comments from you guys to comment on the CAPPELLA? It's our loose widen. You have your product, we have our LV, right?
Yeah.
So, any comments? I saw we have a WeChat. This is a couple questions there. We have a PI, Dr. Wu Zhong, still right here. He can answer the questions.
Yeah, so the question
Okay.
is mainly, what was the window for radiotherapy for the CAPPELLA?
So
Yeah.
there is a window for the final cycle of the neoadjuvant chemo to the beginning of the radiotherapy. The median duration is 25 days, 3 to 4 weeks.
And from radiotherapy to surgery?
2 to 6 weeks.
2 to 6 weeks. So it's very similar to the Prada. And was
Yeah.
there any difficulty during the dissection? Technically speaking, was it more challenging to do that?
Not at all. So when we perform nipple sparing or skin sparing, I think it's quite similar. There is any more challenges to do these.
And those people, there is a very common question. Why don't we do a CAPPELLA or a Prada using implants?
This is a very good suggestion that we are trying to writing a new protocol afterwards. Thank you.
Anybody from the expert panel, any comments on the CAPPELLA study before we move on to the other studies?
Yeah. Actually, I have the same question as Dr. Yazan has mentioned about how do you think about put the expander first and then after PMRT and do the IEP. So, but I have another question. I saw you have 12 weeks after the IEP then to the PMRT. Why is 12 weeks? That's quite a long time.
Well, yes, because according to the waiting period, those patients receiving immediate reconstruction with deep flap, they need some time to recover from the long procedure of the operation. And then when you plan for the post-operative radiotherapy, the patients had a waiting line. They have some plans for the radiation plans and waiting for the list. So in our study, we set up a limitation. It's not exceeding 12 weeks, but maybe they have
like 6 or 8 weeks.
Yes.
That's fine.
Yes.
Okay, understand. Yeah.
Any more questions?
Any more questions about
CAPPELLA?
the CAPPELLA before we move
CAPPELLA
from the
trial,
ground?
yeah.
Anything specific from your side, Andreas? Do you see a difference, or is it just exactly Prada 2?
I think that the concept is rather similar, but it is based on the biologic rationale that we have to take advantage of the 2 to 6 weeks interval until the fibrosis effect of radiotherapy starts to kick in.
Yeah.
I have operated patients like that outside the clinical trial environment, and I can completely echo the comments of the primary investigator that there is no difficulty in dissection. It is completely similar to what you see in an upfront setting. The most important thing that I would like to tone up is that I think that preoperative radiotherapy will give us answers as to how it is going to interact with targeted therapies and primarily immunotherapy. And we will be seeing potentially interesting results in the oncologic outcomes of these patients. And I think that this is definitely the right way forward. I'm very excited about the CAPPELLA trial. I'm very much looking forward to seeing published results and even hosting some of the results in the European Journal of Surgical Oncology.
And and also it's a concept as if we give radiotherapy, well, if there is a residual tumor there, then what sort of immune reaction you're going to get, what sort of response you'll get. It's difficult to know. You need to have long-term data, but it's very interesting, very exciting time. I think
Yes,
that's
but the biological rationale is that we have to expect improvement because breast cancer is immunologically a cold tumor. Converting that into a hot tumor will be able to sensitize tumors even further. And what we have from the literature of solid tumors and how they interact with preoperative radiotherapy and sensitization is very positive and promising. So I think
perfect.
there is a lot to see over there.
And any comments from the panelists in the room before we move to the laparoscopic talk? Perfect.
Any comments or any
Okay.
comments?
So if there's no
No,
comment,
so-
we'll go for 10
okay.
minutes for the laparoscopic talk then. And that was very interesting to see how it's done with the laparoscopic surgery and just doing lipomodeling. Might work much better because of the cup size that you have. It will be very difficult to do it here in the UK. Any comments on that, Andreas?
Well, I think that we have established that minimally invasive approaches have been primarily used in patients with smaller breasts with no ptosis and otherwise favorable characteristics. Now, what we need to take into account, because this is very reminiscent of my local population, is that in approximately, if you look at literature data and also our published data, you can actually avoid mastectomy using chest wall perforator flaps or similar techniques in approximately 96% of these cases. What I think is very promising is that we need to familiarize ourselves with the approach and the technique on the one hand. On the other hand, we need to be aware of the fact that approaches that entail multiple sessions of fat grafting do have a particular registered level of fatigue. We can recall the Dutch trial on delayed reconstruction with fat grafting, where we saw that approximately 70% of the patients did not complete the number of surgeries required to go to a final result. And we need to strongly consider what are we doing to the donor sites in case of a future recurrence where we will need a free flap. So if we harvest from all over the body, then we are devoid of those options in the future, and that needs to be very seriously taken into account.
So before we go to the panelists, questions for the speaker, because fantastic talk, lots of positive comments online. Where do you inject the fat? Do you put it mainly in the muscle, a bit in subfascial, and a bit in the planes? Where do you inject the fat in the first go?
Dr. Song Xue.
Thank you for your question. And in the first procedure, we just put the fat into the subpectoral plane because we have the only layer for the first procedure.
Okay.
And second time, we can put into the subcutaneous plane, and also we can put into the subpectoral plane.
And
yeah.
Do you see problem with fat necrosis? How big is the problem of fat necrosis in those ladies?
Actually, during the follow-up, we do not see many necrosis because we use a common technique, which is very emphasize the multiple plane and very. You need to put the fat very. Just not put too much fat in the same place.
I think the blessing is that you have smaller breasts. We've seen all this Roger Khoury from the States doing all the Brava technique and full breast reconstruction using fat in much larger breasts. I think here you have mainly size A breasts. Any comments from the panelists?
Okay, so Dr. Wang.
Oh, okay. It's my honor to attend these conferences, and this is really, I think Dr. Song, your report is really promising, and I have a lot of questions want to discuss with you. And my first question is similar with Professor Yazan. We have the similar idea that you inject the pectoral, right, for the immediate injection.
Yes.
But we all know that the graphic fat, we want the graphic fat should be alive, and it's totally depend on the blood vessel and also the cavity, right?
Yes.
So the subpectoral cavity is really limited. And I see from your Excel that the minimal volume of your in resection specimen is only 50 gram, I think.
Yeah.
Yes, but you injected 265 grams fat, so that is the 5 times of the specimen. So why did you do that 5 times for of the specimen?
During the first procedure, actually, the dissected specimen is about 173 grams. It's average. It's an average, and we put nearly 200 in the first procedure.
So
because over that,
200 gram fat for
200 millimeter.
Millimeter.
Yes.
For the just under the pectoral fat.
Yes, pectoral. Because over that, you will not do that because the fat will.
Action just blindly.
Yes.
Yes.
Blinded.
Yes. You can see clearly through the incision in the armpit. Yeah.
You don't use this endoscopy, just inject blindly and just clotting your touch, right?
Yes, yes.
Okay, my second question is about your MRI's pictures, because I've seen that from your PowerPoint. I've seen a lot of the fat was just inject subcutaneously. So it is for the cosmetic, I think. So how many times did your patient receive the grafted fat?
I think in my practice, I think the average procedure is about 2, because we choose. Right. Yes, we choose very small breast volume patients, so maybe 2 is enough for them.
So you have 45 patients, but none of them received the radiotherapy, right?
Yeah, none of them receive radiotherapy because we have no data about that patient, that kind of patient.
Okay.
Yeah.
I'm looking forward for your longer outcomes.
Thank you.
Okay, let's.
Very good technology. It's okay.
Okay, so Dr. Wu.
Congratulations, Dr. Song.
Thank you very much.
One comment and one question.
Okay.
I think, I guess you're a plastic surgeon because you have a very good technique for fat grafting.
Actually, no.
Okay.
Sorry.
Thank you. So I know that most surgeons join the multidisciplinary team in the breast units are plastic surgeons who perform fat grafting.
Yeah.
So we are trying to recruit some plastic surgeons. I think they can do very good fat grafting in our team in the future. So if you wish, you can join our team in the future.
Wow, it's a big honor.
And another question is, we have a cohort by my colleague. She's a plastic surgeon, and we placed the expander at the first stage. And then we replaced the volume of the expander step by step in several stages for fat grafting afterwards, and with very good aesthetic results. So what do you comment about this procedure comparing to your method for immediate fat grafting?
Oh, okay. First, I think if the patient had enough the skin envelope, yeah, so we can just do like what our team to do. But some patients, you just afraid of the skin envelope is not enough. Maybe they just cannot preserve the NAC. You do the conventional mastectomy. I will use this the method as you mentioned. First, we put the expander, and then we just need multistage fat grafting to substitute the expander volume. Yeah. It depends on the skin envelope, whether you can have enough skin envelope. If you do have, you can just do as what my team do. Yeah.
Because we had the talk a few years ago, and that has been done a couple of times on the iBreastBook webinars. There's one of the surgeons in Belgium, Philip Stillart, has been doing this for years. Like what you say, Jiong, exactly. That you do the mastectomy, he put an expander, he does not put fat on the first go, and then when they heal, they start week 6, first 100 mils, and deflate the expander. Then after 6 weeks or 12 weeks, another 100, 200 mils, deflate the expander until they reach enough volume, and then take the expander out and put a little augment, and they look like augmented breasts. They look fantastic, which is fantastic to see that you're also doing that. Any more questions on this topic? Because we have 10 minutes to go.
I have some question here to Dr. Yong. Yeah. So Dr. Song, sorry. So I'm C here from Malaysia. So I'm a breast surgeon, but I did fat grafting together with the LD flap for my cases after the training from Thailand. So my question is, do you have a problem when you inject the fat to the pectoralis muscle, whether the patient have some sort of myositis or some sort of inflammation after your injection? Do you have that problem?
I think usually it's very.
Do they have some pain after the surgery? Then that type of pain is a dull type of pain and not really have a inflammation type of symptoms. Do you have that type of experience?
I don't find that adverse effect.
Yeah, because I have a case. I have a case have this type of problem. When I have a LD flap, I inject onto the LD flap. Then subcutaneous as well, and also I inject through the pectoralis major area, but it's very just one thin layer. But post-operatively, patient have that type of pain, and you don't think, because after the mastectomy they do have a dull numbness, you know.
Yes,
but they do have a weird type of pain. So that causing me thinking of maybe there's a cause, the fat cause inflammation to the muscle of the pectoralis major and cause that type of problem. Since then, I never inject on the muscle, then all my patient doesn't have that pain anymore. So a very weird experience, but from one of my colleague, they told me maybe it's a myositis. So might need some anti-inflammatory prednisolone, all that to reduce the problem. I mean, to solve the problem. Just experience on that. Okay. But otherwise, the injection is so far quite safe to us. But Sharon asked me about, what about fat embolism? Do you encounter any fat embolism cases? Because in Hong Kong, they have 2 cases, right, from aesthetic clinic. So they did the liposuction and injection to the face, then patient developed fat embolism. But thank God we are okay. What about you?
Actually, we didn't encounter. And I have a teacher, and I asked the same question to him. It's more common on the face for liposuction to encounter this embolism. But for the breast, it's rare, and no report, even no report for publication. Yeah.
Yeah, I think the fat injection part should be one area to explore, because the natural contour and the absorption part is very natural as compared to our implant, our prosthesis. I think maybe that's the way to go in future, because it really helps us to reduce the fibrosis, reduce all the rippling of the implant, you know. All this is the way to go, I think, probably.
Yeah. Thank you for sharing, Dr. Hong, and any other, Dr. How about you, Dr. Sarayaka?
So I actually very much enjoyed your lecture, so thank you for that. It was
Thank you.
a very interesting technique.
Mhm.
In the United States, the breast surgeons are not typically trained, as you mentioned, to do
Yeah.
fat injections, but I think a very important technique to hopefully continue training breast surgeons in these techniques to help patients with better aesthetic outcomes. In our institutions, the plastic surgeons are doing fat injections to augment for implant-based reconstruction as well to help with the rippling and a lot of the aesthetic issues. So obviously the biggest limitation being the size of breasts.
Yeah.
Also in the United States, probably very limited number of patients.
So
but
the
very-
situation is different.
Yeah,
in,
very
in
different,
Asia
but very
and in America.
interesting. Thank you for sharing. Yeah.
Thank you very much.
Okay, so Dr.
In
Liu,
Europe and
any-
in the UK, we many of us, the breast surgeons, we do our own lipomodeling, our own fat injections. We don't, to be honest, do lots of mastectomies. Our mastectomy rate is lower. So what we do is lots of lipomodeling and scar revision, things like that for the breast conserving, especially if you have changes after the radiotherapy. But it's very interesting talk, very interesting topic. Jiong, we might need to move to the last talk with ask questions about the
endoscopy or a robotic surgery.
robotic surgery, yes. Because
Okay,
it's
so
nearly 9
any-
o'clock for you.
Any comments? Any comments, Dr. Yan? Dr. Yan?
Dr. Yang asked some questions
No,
for
I
robotic
have-
surgery.
No. It's my colleague. And I also have a question for Dr. Song. The previous, yeah, as we know, we place the implant in the post-pectoral space. So sometimes we create a higher higher breast because the pectoral sometimes was higher than the IMF. So you inject the fat in the post-pectoral space. So yeah, do you have some difficulty when you create the projection in the lower quadrant of the breast?
Lower quadrant.
Yeah, the lower part of the breast.
Do I have difficulty
Yeah,
to put the fat?
you initially you inject the fat in the post-pectoral space, and then you in the lower part of the breast, if you have some thin flap in the lower quadrant, do you have any difficulty?
No, but I think the lower quadrant is often the challenge for us to for the injection, because especially in the second procedure, because after 6 months of the first procedure, the second time when the patient came to see you, you often see some adhesions of the skin and the muscles. So the lower quadrant, it's very challenging for us.
That's to losing the adhesion.
Yes. So you just do some release for the adhesion. Otherwise, you cannot put much fat into the envelope. Yeah.
Okay. Okay. So Dr. Gong, any comments? Dr. Gong, Chang Gong.
Can I back to the CAPPELLA clinical trial because I want to ask?
Okay.
Yeah, the question, Professor Wu, do you ever see the cases while post-operative radiotherapy is still required after the proper pro-operative radiotherapy? That means which patients are the candidates for the pro-operative radiotherapy alone without further adjuvant radiotherapy?
Because we cover all the areas need to radiate it. The whole thoracic wall and also the lymphatic drainage area. So there's no need for post-operative radiotherapy for those patients.
Perfect.
Have you? I have idea. Have you ever designed that maybe pro radiotherapy plus maybe short cycle immunotherapy? I think that maybe increase the clinical efficiency.
This is what Dr. Andreas mentioned before, and Dr. Yazan mentioned before. This is a very hot point in the future. Maybe we can organize some subtype studies for the special types of breast cancer.
And oncology and immunology is a fascinating thing, and I think we'll see lots of changes. Am I okay to ask a couple of questions, because it's nearly 9 o'clock for you at night? Am I okay to ask a couple of questions for the last speaker, because the last speaker was so kind to put one of my papers online, so I cannot not ask them any questions.
Okay, it's your turn, Yazan. Yes, it's your turn. You can ask Dr. Wang. He's still here.
What I want to ask really, do you have any different robots in China? Are you using the same robots that we have here? Do you have any different technology? You have fantastic cars, you have fantastic technology and everything else. Do you have any robots that are Chinese robots?
Yeah, we have the single port robotic technique and the multiple port. Yeah, but I just try the single port. Yeah.
And the single port, is it made in China, or is it single
We
port?
both have made in China, or we have both have Da Vinci. Yeah, we have a couple of kinds. Yeah.
And is there any difference when you use this one and that one? Is there any preference?
No difference.
Perfect.
I think it.
That's fascinating, because we don't know what machines, what material you have. It's fascinating.
So maybe you can import some robotic from demonstrated from China.
I need to come and try them first.
Yeah. Okay, you can come here to try.
I think Dr. Wang is young enough to play machines.
Perfect. Any other questions about the robotic talk?
Okay, Dr. Liu, any comments on the robotic surgery?
I have a question for Professor Sharon. Yeah, I want to know, for the Western women has large size breast and usually the ptosis. So for Western women, do you think you prefer the robotic assisted E-NSM? Yeah. You mean if with big breast and ptotic breast? Yeah. So yes, I think will be more difficult. And actually, the consensus statement actually saying that if with size D or above is actually a relative contraindication. So I think especially at the start or of the at the learning curve, it's good to start with smaller case. But we did also some cup size C cup breast. It is also possible, because with the gas insufficient, actually you don't need to do lots of traction, and the wheel is maximized, so it's still possible. Yeah.
Okay, so time is limited. Any other questions or comments? If no, let's go into the closing part. So let's welcome Dr. Jiong Wu and Dr. Shuang and Dr. Yazan to give a closing. So first of all, Dr.
I'll leave it for you first, and then I'll close last. Is that okay, Prof?
Okay, let's lady first. So let's do Dr. Shuang.
Okay, thank you, Yazan, and thank you for all the doctors here on site and on the internet. And where our doctors, Chinese doctors, share our experience of the clinical practice in China and our CAPPELLA trial and our experience in endoscopy and the robotic surgery. And we get hot response from the international colleagues and also our colleagues in China. So I hope we can use this kind of platform to meet together frequently and discuss deeply for all the surgery and plastic surgery issues to make progress by both of us. Thank you.
Okay, good. Yazan, I think all of us agree that this meeting is very productive, and all the speakers are well prepared, and we have very excellent discussions focused on those hot areas. So I think I suggest that the BEST and the iBreastBook had a future collaboration for routine webinar in the future. That will be fantastic. And I think you will agree with me. Thank you.
That's fantastic news, Jiong. If you look at the feedback on the chat function, how much people have enjoyed this. I cannot thank you enough for being part of this. It's really eye-opening to see what you do in China, because there is a bit of limitation what we can see from your side. You can see a bit more of what our side, but it is really eye-opening, and it is really very refreshing to see all that. We had close to 500 people online. There is lots of people that also will watch that. It will be on the YouTube channel. And I cannot thank you enough for staying so late, all of you, just to be part of this. Now, there will be more webinars, and will be more webinars with breast. It will be fantastic to do that. I cannot thank the panelists. I cannot thank Andreas Karakatsanis enough. He's always a good friend, and he's always there with us. And always cannot thank Tatiana, who's doing the Russian channel, Dr. Lopez, who's doing the Spanish channel, and Akram, who's doing the Arabic channel. And it's fantastic to see also Ricardo Pardo, who's been away because of other reasons, and he's back with us now. Now, for people in the States, for people in South America, have a lovely day. For people in Europe, have a lovely afternoon. For people in China, in India, and the Far East, have a good night. Many thanks, everyone, for being part of this. And this will be first, but not last. Many thanks.
Okay.
Dear experts, I believe we all shared unforgotten night, and let's move to the entrance for a group photo. 让我们移步门口来拍一张合照。
You can Photoshop me in the group photo, okay?